Hello everyone, welcome back. Today I'll be covering back pain, diagnosis and management. A part 1 video. Started off with history, physical examination, the basic, the look, feel, move and special tests. I will elaborate more about the straight leg racing SLR test. Now let's get started. History taking in a patient with low back pain. Duration and onset of pain, location of the pain, characteristic of the pain, aggravating and relieving factors, any radiation of pain, whether associated with numbness, weakness, or bowel or bladder disturbances, any constitutional symptoms, any treatment received, and the response to the treatment. The red flags history in patient presenting with back pain. Age more than 50 years old, that means older age. Pain at rest, non-mechanical in nature. Pain at night disturbs the sleep. Pain more than 1 month and there is no improvement despite analgesia. Sciatica pain. Pain associated with fever or previous history of urinary tract infection, UTI, skin infection, upper respiratory tract infection, URTI. Unexplained weight loss, previous history of fall, previous history of cancer or significant family history of cancer, past medical history, immunosuppressive, example in diabetes mellitus patient, rheumatoid patient, SLE patient. Drug history, corticosteroid usage, prolonged, intravenous drug user, chemotherapy or radiotherapy. For physical examination, start off with look. Observe the patient gait as well as the body position chosen by the patient. Patient with acute sciatica may choose to avoid sitting in a slouch position as this places extra pressure on the impinged nerve root. Expose the back. Look for any redness or warm or hairy patches or skin defects. Look for any presence of muscle atrophy or any asymmetry of the back or the lower limb should be documented. The range of movement ROM of the spine is tested. Pain that is aggravated by flexion shows a disc problem. Pain during extension points to stenosis, facet arthritis, or spondylolysis. This figure shows the disc pressure based on the sitting position and the effect of posture to the disc pressure. The disc pressure was measured between 3rd and 4th lumbar vertebrae. The results are presented according to Nathanson and Elfstrom. So as you can see, from standing, the back angle the pressure is around 100%. As the angle of inclination decrease, there will be an increase in the disc pressure as illustrated from 110 to 80. Once the 110 is only 105% of pressure, but when it comes to 80, it is about 190% of increase in pressure. For physical examination, feel. We palpate the spinous process. Tenderness may indicate an acute osteoporotic fracture. Tenderness at the area of the posterior superior iliac spine indicates pain from the sacroiliac SI joint. A palpable step-off between the spinous process indicates a spondylolisthesis. This first picture shows how to palpate along the spinous process. The second picture shows the Fortin Finger test, whereby the patient will point pain in a specific location. The area pointed is at the sacroiliac region. Next physical examination is move. A complete motor and sensory examination, including the deep tendon reflex, is essential. Dermatomal sensory deficit and muscle weakness may indicate impingement of a specific nerve. We will discuss a bit regarding ASIA chart, but full explanation will be in another video. This figure shows the ASIA chart. You can see it is based on the dermatological and myotome of the patient. So, based on whether it is full power M5 to 0 power M0 and the sensory all need to be documented properly during examination. Regarding special tests, the straight leg raising SLR. The SLR test is also known as Lasegue test. It is basically a provocative test used in detecting disc herniation and nerve compression. The SLR requires the patient to be in a specific position. It requires movement in certain joints. Among the contraindications for SLR are patient refuse for the test, patient unable to lie down straight due to any underlying issues such as serious spinal disease, advanced scoliosis, etc. The patient has advanced knee or hip joint disease, making the procedure excessively uncomfortable for the patient. The SLR is performed with the patient in supine position. The examiner gently raises the patient's leg by flexing the hip with the knee in extension, and the test is considered positive when the patient experiences pain along the lower limb in the same distribution of the lower radicular nerve root, usually L4, 5 or L5 S1 region. The positive SLR is when the pain is elicited by lower limb flexion at angle less than 45 degrees, or when there is radicular leg pain occurred, whereby radiating below the knee. The buttock pain is usually relieved by flexing the patient's knee. This picture illustrates the straight leg raising test, LSR or Lasegue test. The examiner lifts the extended leg of a patient in a supine position. Positive when the patient experiences pain along the distribution of the lumbar roots. Usually pain occurs during knee extension less than 60 degrees. What findings should not qualify as a positive SLR? Number 1. Pain occurring in the low back alone. 2. Pain occurring in the posterior thigh alone. 3. Pain occurring at an angle less than 30 degrees. It may indicate non-organic cause or hip joint pathology. Number 4. Pain occurring at an angle more than 70 degrees from the horizontal. More likely cause is tight hamstring or gluteal muscle. Number 5. Pain occur in a normal person at an angle of 80 to 90 degrees. This figure shows the straight leg raising test. And if over 75 degree, practically no further deformation of root occur during further SLR. Additional maneuvers to enhance the test sensitivity. Example, Bragaad sign, which consists of concomitant foot dorsiflexion to increase the pain. Another maneuver is the cross SLR, crossover Lasegue, in which the examiner passively flexes the patient's uninvolved limb while maintaining the knee in extension. Positive when patient complain of pain in the involved limb at 40 degrees of hip flexion with the uninvolved limb. Across SLR is positive with central disc herniation in cases of severe root irritation. This figure shows the Bragaad signs, whereby the concomitant foot dorsiflexion was done that increased the pain while doing the SLR. This is considered positive. Usually the angle is less than 45 degree. Further examination. In patients where there is concern for cauda equina syndrome, a rectal examination and perianal sensation pinprick testing should be performed. This first picture shows how to do the per-rectal examination by inserting your finger into the rectum, and we need to rotate it to assess for any masses, hard stool, any impaction, any painful areas that shows any anal fissures or internal hemorrhoids, and you must test for any anal tone or legs. The second figure shows the pinprick sensory anal sensation test. If there is an impairment, pain is reduced or no perianal sensation present while doing the pinprick. Finally, an examination of the hip should be routinely performed, as there is significant overlap in clinical picture between the hip and spine disorders. The 5 physical examination tests are: 1. Flexion, abduction, external rotation, FABER test. Number 2. Thigh thrust. 3. Pelvic gapping. 4. Pelvic compression. 5. Gaenslen test. This is useful to identify whether the problem is due to posterior hip joint or the posterior superior iliac spine PSIS. This first figure shows the Per-rectal test or FABER test. Patient can be lie down or in a sitting position. You need to lift the affected leg and do a flexion, abduction, and external rotation of the hip. Patient will complain of pain if it's positive. For Gaenslen test, usually is positive if pain is felt across the sacroiliac joint. It has a 68% sensitivity and 35% specificity. What you do, patient will be lying down. The examiner will push the non-tested side leg in a flexed hip and knee joint towards the patient's chest. while the tested leg, which is allowed to fall over at the side of examination table, is pushed towards the floor. Positive again if patient felt any pain. Yay, we have reached to the end of this video. See you in the part 2 video. Take care and bye.